presentation today is going to look at mobile integrated healthcare community paramedicine programs, and it's basically a 101 or an introductory course. Now, my presentation draws very heavily on some experiences that I've had recently as an employee or a contractor with Nature Coast Emergency Medical Services up here in Citrus County. And these included the research, design, and implementation of interview surveys with Florida EMS agencies that self-reported operating MIHCP programs. There were 2 educational programs that were designed and facilitated, and one was a face-to-face classroom style program, and the other was an online program that was co-facilitated with another colleague. Now, all these activities culminated in the design and co-authorship of the Mobile Integrated CP Guidebook that was published by the Florida Department of Health. And throughout the presentation, MIHCP is Mobile Integrated Healthcare Community Paramedicine. So what we'll cover today, we're going to look at MIHCP. We're going to look at a couple of different definitions, how it's defined. We're going to take a look at some of the models of MIHCP. Then we're going to leave the national level and we're going to head down into Florida, and we're going to drill down into what some of the programs in Florida are doing. We're going to end up with answering the question, why MIHCP? And this is basically, why do we think MIHCP is a good idea? Well, why would you even consider one of these programs? And we'll take a look at some of the evidence that's available in the literature. So today's formal objectives are, I'm hoping that you'll be able to identify at least one MIHCP model, that you'll be able to describe the connection between rurality and MIHCP, and hopefully that you'll think about your community and identify one barrier to care that may be addressed by an MIHCP program. The informal objective, and I'm going to state this as I often hear my colleague talk about it, is that you will drink the MIHCP Kool-Aid, that you'll leave the session being a believer and will go out and champion this type of program. So we're going to start off with from whence these programs came. Now, the following 2 slides present a timeline of what I have defined as the key milestones. And in the literature, you're going to notice that maybe it doesn't quite conform with these. But this is my take on the key milestones. Now, MIHCP is really the epitome of the expression that MIHCP necessity, right, is the mother of invention, or rather innovation. The Paramedic Foundation states that the modern concept of community paramedicine can trace its origins as far back as 1968 in Alaska with the Community Health Practitioner Program. Red River is credited with being the first MIHCP program in the country, and that was 1993. In 1996, the EMS Agenda for the Future described what we would now define as community paramedicine, but didn't explicitly call it that. In 2001, the term was coined and came out of some rural Maine experience. In 2004, the United States Department of Health and Human Services, HRSA, the National Rural Health Association, in their Rural and Frontier EMS Agenda for the Future, talked about community paramedicine. In 2007, the specific title CP was adopted. In 2013, the National Association of EMTs conducted an MIHCP survey, and at that time they estimated that there were over 100 programs in the United States. So they sent out their survey, and folks responded back describing the kinds of work that they did under the umbrella of MIHCP. In 2014, the U.S. Department of Health and Human Services, HRSA, published the Community Paramedicine Evaluation Tool. And that's a rather extensive document that really takes people through what the process would be if you were considering setting up an MIHCP program. In 2014 as well, the National Association participated in the International Roundtable on Community Paramedicine. 2014 also saw the National Association creation of a vision statement. Now, 2015, Pueblo of Laguna, which is a program in New Mexico, was started. Now, that's one of the other projects that's identified by the Paramedic Foundation as being sort of the genesis of modern MIHCP. In 2018, the National Association of EMTs sent out their second MIHCP survey. And at the time of the second survey, they estimated that there was an excess of 200 MIHCP projects in the country. So you can see the proliferation that took place between 2014 and 2018. So what do we know about these programs? What do we know about their genesis? What are the areas that have birthed MIHCP have in common? What need might these programs be addressing? Well, first, these areas all share a lack of health manpower, primary care providers, or just about every other kind of provider. Their locations are rural and in some cases considered frontier, with population densities of less than 6 people per square mile. Historically, these areas are isolated both geographically and socially. And all these areas that birthed MIHCP are areas that share characteristics like ruralness, lack of health manpower, and they're home to socially and geographically isolated populations, as well as chronically medically underserved and populations with special needs. Now, when I think of rural, I think of ruralness as a driver of the healthcare system, or rather the lack of the system, the lack of facilities, and the lack of providers. That in turn, the lack of facilities and providers really drive, along with the social determinants of health, the health status of rural populations. So what do we know about the health status of rural populations? Well, CDC has published quite a lot of data on rural populations. And what they state is that rural county residents die from the top 5 causes of death more frequently than their urban counterparts. And those 5 causes of death are cancer, heart disease, unintentional injury, chronic lower respiratory disease, and stroke. CDC goes on to say that many of these deaths are likely preventable. So what do we mean by preventable? Well, what we know with things like cancer, particularly breast cancer, colorectal cancer, is that detection at an early stage really helps with the prognosis. Okay, if you can identify cancer early, you can treat it when it's in a stage where it may be more amenable to treatment. Okay, heart disease. We know that if you reduce the risks associated with heart disease, the death may be prevented. Chronic lower respiratory disease, we all know the connection between smoking and these types of diseases. Hypertension and stroke, okay, there's a clear relationship. If you have high blood pressure and it's not controlled, the likelihood is you'll wind up with a stroke. So in that regard, many of these deaths are preventable. So what else do we know? It's sort of in rural communities, there's this perfect storm taking place of a lack of provider and prevalence of risk factors. So compared to urban populations, rural populations have higher risk rates of cigarette smoking, high blood pressure, and obesity. Folks in rural areas tend to engage in less leisure time physical activity, and they tend not to use seatbelts. They have higher rates of poverty, less access to health care, and is less likely to have health insurance. Now, lots of times in rural areas, service industries are major employers. And these are typically or rather notorious for not providing benefits, particularly around health insurance. Yeah. So again, CDC claims that compared to urban population, rural populations are less educated, and they have limited public transportation or transportation options. Lots of times, even if they have a car, if they're poor, they can't afford gas to get around. So transportation is an issue. There's also, as we talked about before, lower population densities, and these all affect whether or not a program can establish an economy of scale. Now, this table displays some death rates for some Florida rural counties, and they were selected not for any other reason except I'm more familiar with them. And the table shows total deaths, cancer deaths, heart disease deaths, chronic lower respiratory disease deaths, stroke, and unintentional injuries and falls. And you can see that the Florida rate is the first row across, and it's in black. And where you see the red type, that's where the county has a rate that's equal to or higher than the Florida rate. Now, this holds true for all but 2 instances in deaths due to stroke and 2 instances in death due to unintentional injuries and falls. And what this table basically demonstrates is that in these rural Florida counties, they mirror the trends that are going on in the nation as a whole. Now, I include unintentional injury of falls because to me in Florida, with the aging population that we have, it's really the low-hanging fruit. If I were starting an MIH CP program, that is probably one of the first places I'd look. The elderly population tend to be a little more socially isolated, so these kinds of programs really get them outside of themselves and engaged in something else. And I believe the payoff for those programs is pretty high. So what is MIHCP? The MIHCP was defined by the National Association of Emergency Medical Technicians. And according to them, MIHCP is the provision of healthcare using patient-centered mobile resources in the out-of-hospital environment. It's provided by a wide array, MIH is provided by a wide array of healthcare entities and practitioners that are administratively integrated with EMS agencies, while CP is one or more service provided by an EMS agency and practitioner that are administratively integrated with other healthcare entities. And you can see the distinction they're making between MIH and CP, and it basically has to do with who the sponsoring organization is. So in this survey, they also asked folks to report regarding their model, or what was the focus of their program. Now, 78% of folks said that they focused, or their model was focused on readmission avoidance. And this model focuses on folks that are at high risk for readmission to the hospital within 30 days of their discharge. Typical diagnoses include congestive heart failure, pneumonia, hip and knee replacement. 78% said that they focused on frequent users. Now, these are the folks that use the 911 system more frequently than their neighbors, I guess is a good way to describe it. I've seen various estimates of what constitutes a frequent user, and it's typically defined by the organization based on their experience. 67% talked about chronic disease management, and this is basically a model that focuses or provides home visits to patients to educate them on what they need to keep healthy, to get healthy, to avoid readmission, and to self-manage their conditions. Typical conditions include congestive heart failure, hypertension, COPD, asthma, and diabetes. 50% talk about alternate destinations. And this is really focused on providing the least resource-intensive type of care to meet the patient's needs. So these other locations may be a detox facility, They may be a primary care office. They could be an urgent care center, or the patient may actually be able to be maintained or treated at home. 45% claimed that their model was a primary care extender model, and this is very typical. And in the earlier programs that we talked about before, was usually the model that was provided. We all know that our health system is very fragmented. It's really an opportunity for folks to step up to the plate and really provide some coordination. 20% said that they engaged in home health or hospice support. 19% said other, and basically the other category includes services or medical procedures or care that could be successfully managed at home, and things like wound care or trach care fall into that category. Now, the nurse triage model, I basically think of that as an alternative destination model. And this is where low acuity calls coming into 911 are sent to a nurse triage center, and they evaluate what is the most appropriate response based on the client's acuity. So the goal is to get them redirected from an ED into the least resource intensive environment that can safely handle their condition. So what's Florida MIHCP? It's very similar, as you would imagine, to the national definition, and it was defined by the Access to Care Committee of the Florida Emergency Medical Services Advisory Council. And they state that MIHCP is the provision of healthcare using patient-centered mobile resources in the out-of-hospital environment. They also go on to say that MIHCP is provided by a wide array of healthcare entities and practitioners that are administratively or clinically integrated with EMS agencies and other healthcare entities. Now, it's very similar, but they don't quite make that as sharp a distinction between MIH and CP. And I find this definition to be a lot clearer and easier to understand. So what do we know about Florida MIHCP? Well, the Florida EMS Agency conducted a survey, and in that survey, they asked folks if they were providing any kind of MIHCP program. And you can see that almost 17% said they were. Now, if they weren't providing these services, they were asked what barriers were there to doing this. The majority said funding, and that's not surprising. Almost 75% said that that was a major barrier. 64.4 said personnel was a limiting factor. 13.3 said medical direction. And 25.2 stated that they were uncertain regarding how to start up or implement a program. And folks could go ahead and pick more than one response. So what else do we know? Well, if they were providing MIHCP, they were asked what was their staffing model. And you can see about 78% said paramedics, as you would expect. EMTs was a little bit over 20. Registered nurses were used on some of these teams, as were social workers and mid-level practitioners. Now, the other category includes professionals from the mental health, substance abuse world, behavioral health world, and also pharmacists. Folks were also asked what the focus of their programs were. And you can see that almost 50% focused on cardiovascular health, about 45% diabetes, and 45% respiratory health. And this isn't surprising at all, given the causes of death that we just looked at before. So what do we know about rural Florida MIHCP? Well, there's currently 5 counties in Florida that are either operating or beginning to operate an MIHCP program. And this information, the source of this information was personal communication with Jane Bedford, who introduced herself before. She's the rural EMS coordinator for Florida. So I expect as we see more development, the rural areas seem to be very ripe for development. So why MIHCP? Do we have any evidence that these programs work? Why is it a good idea? If you consider that it's one that's been around since, as we talked before, roughly 1968, and if the number of articles published and the returns that you get when you Google the term is any indication, I'd have to say that it's thriving. There's been increased national attention from the federal Centers for Medicare and Medicaid, and that interest may signal that there's maybe some changes coming down the pike that may eliminate the #1 barrier to starting and sustaining a program, and that's how to fund it. So funding, especially in rural areas, is going to inhibit the program development and implementation. And I always think about an interview that was conducted with a large urban fire-based service that started a program. When asked about how it was funded, the response was that given the size of the overall organization and the fact that it had a multi-million-dollar budget, that the MIHCP program was, the whole budget for that program was almost considered a rounding error. That's how big the organization's budget was. All right, you're not going to see this in a rural area. It's not the case in a rural area where the budget for the MIHCP program may rival the entire organization's budget. It's also interesting that the proliferation of programs in some areas has to do with whether or not the state provides Medicaid reimbursement for these services. And I think that's a trend that we see in Minnesota. So why MIHCP? What do we know from the second national survey? Respondents to the survey were asked to rate their program as highly or somewhat successful in showing change. 72% of the respondents said that they improved the overall status of their clients. 7% said that they reduced or they had a positive change in cost savings for their defined group of patients. 73% said that they reduced 911 utilization. 74% said that they reduced reliance on EDs. 73% reduced 30-day readmissions. 85% achieved patient satisfaction. Now, this was self-reported, where respondents were asked to rate their own programs, so it's subject to the limitations that any self-reporting would have. So why MIHCP? I call this the review of the review. This was a joint effort of the National Rural Health Resource Center and the Paramedic Foundation. And they published a document titled Community Paramedicine Impact Reference Guide, and it was published in May of 2020. And this is an exhaustive compilation of articles about MIHCP, and they start in the 90s and they work their way to the present time. And the early work focused primarily on a description of sort of the structural elements of MIHCP, sort of what was needed, what these programs were, and what they looked like. As the programs evolved, the literature evolved, and there was more of a focus on trying to understand the impact of the program and whether or not they had a positive impact on their client base. So I refer you to that as an exhaustive treatment of the subject. So one of the articles that was presented in that compilation was published by Greg and his colleagues. And that was published in 2019, and it's a systematic review of community paramedicine and EMS mobile integrated healthcare interventions. It was published in 2018, And what this study did was it looked at 8 other studies that were conducted in 2016, 17, and it should be added 2018. And the measures that they looked at are those associated with the Institute for Healthcare Improvements, triple aim: improve health status, reduce cost, and maintain and increase patient satisfaction. And here's what they found. They found that 3 programs or 3 interventions looked at health status and reported that the health status improved. Now, all of the studies included at least one utilization and cost measure. ED use was reduced in 5 of the 6 studies that examined this variable, and in the 6th study, there was no difference. ED costs were reduced in 3 of 3 studies that looked at that variable. Inpatient use was reduced in 5 of 6 studies with an increase in 1. Length of stay was reduced in 2 of 3 studies with 1 reporting no difference. Inpatient cost was reduced in 2 of 2 studies. Emergency medical services cost was reduced in 1 of 1 studies. And regarding patient satisfaction, 3 studies increased patient satisfaction and 1 reported no difference. So now we're going to take a trip to Texas. MedStar is a large MIHCP program. It's well known through the country. It's done a lot of work around MIHCP, and it's taken a look at the impact these programs have on their clients. One of their programs or models is focused on readmission. And this program enrolls clients at risk for a 30-day readmission. They coordinate, community paramedic coordinates intervention and treatment with the primary care provider, and they provide a bridge between the primary care provider and the client so that care can be coordinated. Now, what they found was in the study population with a high risk for readmission that they experienced a 52.5 reduction in readmissions. They also have a model that focuses on high utilizer group, or the EMS loyalty customers, clients, patients. Now, they've defined a high utilizer as a client that uses 911 15 or more times in 90 days, or is referred by ED case managers. Now, they provide regular home visits and teach self-management to this group of high users. And for this group, they were able to demonstrate that they reduced ED visits by almost 3,500, and they prevented almost 1,600 hospital admissions. And based on that, they project that they've saved $23 million in healthcare expenditures for ambulance, ED, and admissions. Another program model that they operate is a 911 call center RN triage. And in this model, low acuity 911 callers were referred to appropriate resources. They identified 12,226 low acuity 911 callers that were referred to the program. And they've established that almost 38% of the clients they were able to divert from the use of an ambulance to the ED to another response. And that diversion saved $6 million in healthcare expenditures for ambulance transport and ED expenditures. So what do we know about the Florida experience? What do we know? What's the Florida evidence? Okay, Ken Peach, who's the executive director of the Health Council of East Central Florida, who's also an ECHO panel participant, prepared a poster for the Institute of Healthcare Improvements meeting, and it's titled Paramedicine Extends Primary Care into the Home. And as the title suggests, it's a primary care extender model. And I took this graphic from his presentation because I thought it did a really nice job of showing succinctly what some of the differences between EMS paramedicine is, sort of the traditional, right? And chronic care paramedicine, or what we're calling community paramedicine. And for the EMS paramedicine line, you can see that there's 4 stages or steps, right? Dispatch, triage, treat, and transport. In the chronic care paramedicine or community paramedicine model, you have physician referral into the program. You have a very complete assessment. The community paramedic can go into the home and make a very thorough physical, social, mental, environmental assessment. A report is generated, and then the physician and the community paramedic with the patient would define or create a plan to manage that condition over time. So I like the way this model sort of summarizes it. Now, Ken also provided some results for the West Orange Healthcare District Healthy, Happy, and Home program. And you'll see 2 lines. The blue line, or the higher line, shows prior 36-month actual experience with hospital admissions. And I think about that as what the expected rate might be. And then you look to the gold line, which is at the bottom, and that's the actual 2-year experience. So what we're seeing for hospital admissions is that the actual 2-year experience is lower than the prior 36 months actual, which may be defined as an expected. So in this case, and it's sort of like, this is a good, air quotes, impact. So other results for the West Orange Healthcare District Healthy, Happy, and Home program looked at hospital readmissions. And again, this was of 4 time periods. And again, we have an actual readmission rate, which is blue and on the bottom, and the anticipated readmission rate, which is on the top. And you can see that there is a difference, right? The actual didn't come anywhere near the anticipated or expected. And again, this would be, I would define this as an air quotes, good response. So another program that I looked at was one that's operating in Manatee County, and it's the Manatee Community Paramedicine Program. And Dr. Reinhardt and her colleagues published this article that's titled Incorporating Pharmacists into Mobile Integrated Health Teams, a Cost-Benefit Analysis. And these pharmacists were integrated into the mobile healthcare team in Manatee County. Now, Manatee Paramedicine Program provides a wide range of services that target populations like folks that frequently fall, that result in frequent calls. They also targeted mental health and substance abuse clients, diabetic clients, congestive heart failure, and chronic respiratory conditions, folks with those kinds of conditions. They also focus on high system utilizers. Now, what this program does is the community paramedic services are paired with a consultant pharmacist who provides medication reconciliation, medication therapy management, and addresses issues like non-adherence and identifies potential and actual adverse effects. Now, the consultant pharmacist is involved or cross-cuts all those models of Manatee's community paramedicine program. And Dr. Reinhardt and her colleagues provide some results. What the authors did was they looked at the cost of the pharmacist paramedic program versus what they projected to be the savings to payers per year. And what they're showing is that the savings to payers was based on ambulance diversion, ED avoided visits, and hospitalizations, and that by far the savings to payers more than exceeded the program cost. Again, defined as air quotes good. This summarizes some of the costs prevented, and you can see that $7.8 million in costs were prevented for ambulance transport, ED visits, and hospitalization. They estimate that 1.5 million program costs were prevented in the area of adverse drug events, and a little over 3 million in the non-adherence. Now, this graphic summarizes the different kinds of pharmacist intervention that was performed over the 3-year period. And you can see that non-adherence correction was 145, adverse drug events avoided is 313, other kinds of intervention that included dosage adjustments was 253, and total medication interventions for the 3-year period was 711. Now, when I look at this chart and I see non-adherence corrected, what that means to me is I have hypertension. I'm not taking my medication to control my high blood pressure. I'm now taking it. Now, remember everything we talked about risk factors and cause of death? So this ultimately will have an effect on cause of death. Adverse drug events avoided. Lots of times these drug events can have very serious consequences, including death. So when I look at this, I think the value of a pharmacist on these teams to handle these kinds of interventions is really invaluable. So then we're going to head to Gainesville. And this is an article in which Jonathan Bassett asked 5 questions of Ariella Bach. Now, Ariella Bach is with the Community Paramedicine program in Gainesville. And Ariella described the origin, status, and funding of the Gainesville Community Paramedicine program, which is called the Community Resource Paramedic Program. And what she said was that early observations include a 50% reduction in ED visits, a 44% reduction in missed or canceled primary care visits, and a 58% reduction in admissions to the hospital. Again, these could be defined as sort of air quotes, good outcomes. So we've taken a look at what some of the evidence is, and I'd like to end up with the 7 reasons that mobile integrated healthcare community paramedicine programs benefit everyone. And this was written by a fellow called Kevin Emmel, and you have the reference below. So what he basically says is that these programs lower superutilizers, okay, the frequent callers. They relieve the EMS system in 911 calls. They educated and helped the underserved populations, which I think is extremely important when we consider that what they're doing is they're going in and they're teaching people, educating people on how they can self-manage their conditions. They also provide the proper care for the caller. So again, getting the client hooked up with the least resource intensive, safe place for care. They reduce hospital admissions and readmissions, and they build more trust with the community. And we haven't talked about that, but that's a very important one, I think. And it has to do with creating social capital in your community. And the more social capital you build, the more trust you'll have. When you're providing a service that people value, that can that shows that you can help improve their quality of life and their joy of life, you're going to build up some social capital. And the last one that is claimed is that it's easier to do than ever before. And the author makes a pitch for its company, who is a technology company. But when you think about it, it really is easier to do now than it ever has before. There's tools and techniques and evidence-based practices. I mean, there's an abundance of mechanisms that you can use. There's case studies that you can look at. I mean, there's just a wealth of information on MIHCP programs. So I think we've come full circle. We started off talking about what is MIHCP, how do people define it, what it looks like in the nation, what it looks like in Florida. And then we ended up with a description of why it might be a good idea to carry out these programs. I think the future of MIHCP is sort of slated for expansion. That would be my sort of take on it. It is a program that's sort of poised to sort of explode. And I'm hoping it explodes in Florida. And I'm hoping that coming down the pike, we'll see some very favorable changes in reimbursement. I think we'll see a level of sophistication in some of the evaluation and research studies that are done around this to document the outcomes. And I'm hoping that the evidence can meet up with reimbursement so that the evidence can prove or document that these programs work and that they're a worthwhile endeavor. So I want to thank you for your attention. If you have any questions, please email me at jerriregan@outlook.com.